work as possible, the brain risk cases and eligible, which being documented, and the consented cases, which is more than 1,444 cases, and actuals, which are being utilized, is 1,311, which shows that, again, this is the activities which been done long time and consistent, and as a result of this, we have so many patients being transplanted from the deceased donor and living donor. The total deceased donor from kidney is 2,227, and from living donor is 4,395. And as you can see, the number is increasing. This year, we expect that we will have almost around 700 or 750 kidney transplant. This is for the deceased liver transplant. We have total numbers of 571 cases now, and the total living is 358. Also, there is a booming now in living donors liver transplant at both centers, King Faisal Specialist Hospital and National Guard Hospital, and this year we'll have much more than the numbers which we had before. About heart transplant, we have medium of 20 heart to be transplanted every year, and recently there is a new initiation again from military hospital in Riyadh. They want to start their program again, active program again, and I hope that in the future we'll have more. We start to use the heart for valve since 1993, and as you can see in green, there is a lot of heart being used for valve with co-work with the King Faisal Specialist Hospital. This is the deceased organ donations. As you can see, we had 2,227 kidney and liver 571, whole heart 187, and we used heart for valve 517, and pancreas 18, and lung is 45, and cornea retrieved locally 632. For the living kidney, 4,395, and for the liver, 358. And we had, again, the regulations for unrelated, non-commercial transplantation, and this is very rigid program, which again, we have few numbers for kidney and for livers coming from out of this program. The kidney graft survivor and patient survivor is quite comparable to anywhere in the world in the developing country. The patient survivors in 3 years is in 3 and 4 years is 93.2 for the kidney, 0.2%, and 81.7% for graft survivor. And for the liver, from diseased donor in the 3rd year is 83.1, and for living donor is 91.2%, which is very good numbers. And for the heart, in the 4th years, we have 76.4% outcome. Now, organ sharing program between Kingdom and other countries, we have almost 178 organs shared between us and different countries, including the GCC. And this one, so the GCC contributions, and as you can see, the highest number is between Saudi and Kuwait, and then Qatar, and recently Bahrain, and before we have a good cooperation between Spain, and we have 17 organs from there. And there is a derivative between kidney, liver, whole heart, and lungs. Again, if we compare our work in Scott in 5 years, compare 2000 to 2004 versus 2005 to 2009, we will see there is a significant increase in number of donations, significant increase in numbers of transplantation as well, and also in reporting. Hopefully we can continue like this and continue in a steady state in order to have more organs to save more patients. Again, this is the same comparison which shows the difference between 5 years and another 5 years to show that still our work is good, but it's not enough to come back with high patients. We have our annual report. It is very transparent report about all the organs, and everyone can reach it and can see it. And by the way, if you can notice that we are the reference center in GCC country, we've been recognized as the reference centers in in Gulf country since maybe 5 years now, and we continue doing our job, and hopefully we will continue to be the reference in the area here. Saudi Arabia became again one in the map in the world, and still, if we compare the deceased donors with living donors, we still need to work more in both sides in order to be in the middle and to be like with what we hope that will be like US, Sweden, and UK, in order to have both sides, deceased donor and living donor together, and to be shifted to in the mid of the map of the world. I conclude, Mr. Chairman, that organ transplantation is very well established modalities of therapy for end-stage organ failure in the kingdom, and all types of transplantation should be encouraged to reach self-sufficiency. Saudi Arabia has a strong collaboration with Gulf countries in the field of organ transplantations and donation. Thank you very much.
Thank you, Faisal. Thank you very much for an extensive review of the situation of organ transplantation and donation in the kingdom. I will ask Dr. Adnan Al-Alfi to introduce the next speaker.
The next speaker is Dr. Ali Al-Ubaidli. He's from Abu Dhabi in the United Arab Emirates. Dr. Ali graduated in 1997 from Ireland, and he finished his postgraduate studies in nephrology and renal transplant in 2005 from Canada. He's at the moment a consultant nephrologist and transplant physician at Sheikh Khalifa Medical Center in Abu Dhabi, and also consultant nephrologist Imperial College London Diabetes Centers in Abu Dhabi, and as well Chief Clinical Officer in an Abu Dhabi Health Service. Dr. Ali.
شكرا دكتور علي. Let me go back to what Faisal said. Faisal said that he is a student of Professor Muhammad Ghanim. He should continue without interruption. So I'm a student of Faisal, who is a student of Muhammad Ghanim, so I should also continue to the end. Well, thank you for being here. I would like to just go over UAE experience. I don't need to orient to where we are, but I will visit this theme later on during the talk. A little bit about the history of organ transplantation in the United Arab Emirates. That prior to the 1991, we had approximately 63 living-related kidney transplant surgeries done. And the actual transplant surgery started in the early to mid-80s. After that, we had occasional transplants. There was no formal program, with most post-transplant cases followed by nephrologist, and for liver by general hepatology. One of the issues was that the brain death law was not fully addressed to permit deceased donation. Recently, we were able to put together a transplant program team, and that has a surgical part, transplant nephrologist, coordinators, pharmacists, and with that we started our living-related donation. So to date we have, over the last 2.5 to 3 years, 47 living-related kidney transplants. 3 of them were UAE nationals and 44 expats. No organ procurement organizations exist. And the status of the brain death law, I can highlight to you as we proceed. So these are the cases that were done since end of 2008 to 2011. If we go over the results so far, we see that these are comparable. You can argue that our numbers are small, and do we have the power to compare it? However, so far we are accepting lower risk donors and recipients, and we have good results. And these are our results when it comes to some complications such as rejections, infections, lymphoseals, vascular complications, urological, and delayed graft function, which compares to the literature. The immune suppression is variable dependent on our team. We had a surgeon who left us now, but he was trained in Pittsburgh, and he was using Campath and other induction. And immune suppression maintenance consists of tacrolimus or cyclosporine, MMF, and prednisone. So, of course, the goal of this program is to meet the transplant needs of the country using resources within the country to be in line with the Istanbul Declaration. Well, there are challenges that hinders or stop us in moving full speed in this direction. So there are lots of investments to be made when educating the public. So recipients, they seem to want to travel abroad, and it's easier not to look hard when the outside door is open. I'm glad to see that with a great teamwork of the international transplant community, that the option to go and outsource our problems outside is just getting closed day after day, and this is very healthy for us to respect the integrity of our healthcare profession and help build ethical programs. Donors are predominantly expat population, market, cultural and language differences, and often many of the donors live abroad. Now, UAE population, we are waiting for the 2011 official census, but we are estimated as of 2010 to be around 8 million, perhaps 20% or less Emiratis, the rest expatriates. And you can see that we are overall, when it comes to UAE nationals, we are young generation with more than 50% under 20 years of age. Little statistics about end-stage renal disease. We have in total 1,300 patients on dialysis. The majority are dialyzed in Abu Dhabi. Abu Dhabi is a bigger emirate. It has 86% of the land. And it is for free, whether it's for UAE national or non-national. Our government feels that these people contributed to building the country and they deserve to be treated for free. And our program screened many candidates. As you can see the numbers, more than 300, close to 400. 47 were transplanted. Many people transplanted elsewhere. And we know that there are 19 ready for transplantation. Now, there are some challenges if we wanted to proceed with deceased donor transplant program. One challenge was that although we have our presidential decree of 1993 permit organ transplantation from living and deceased, but it did not specify that deceased also meant brain death. We also need to invest in building the right OPO. And then given the fact that we have predominantly expat population, we need to keep in mind the different cultures that exist, the challenges in obtaining consent when it comes to relatives, and then the fact that we also have some transient population. We have to factor this in if we want to educate the public in maintaining the education. Well, when it comes to brain death, this audience knows very well that we have to address it from legal, religious, healthcare professionals, public, and media perspective. And if I could just take you through the steps that we have done to show that we are in the very near future starting our deceased program. We had a 1993 federal law as I said earlier, permitting transplantation from deceased as well as living. Item 6 on this law permitted the transfer of organs from deceased and dead individuals, and death was to be verified by a committee of 3 specialists, one of them to be a neurology specialist. The legal consultations that we have done show that we had 2 options, either because of the Islamic perspective of Amman in 1986, and this law was issued in 1993. We could assume that this, by default, covers brain death sources and just proceed with implementation. Option 2 was to amend the federal law to permit cadaveric donation from brain death sources. So we proceeded with option 2. We also needed to work very hard to not contradict, or at least clarify to the decision makers that the federal medical liability law of 2008, which stated that patient's life should not be ended by for any reason, even if requested by the patient or his or her guardian or custodian, that this doesn't contradict. So we needed to approach few stakeholders. We got the official Ministry of Islamic Affairs and Awqaf, so we got the fatwa dated 2006, supporting the withdrawal of life support from patients with brain death. And that what helped us that this practice was already practiced in the rest of the GCC. And the other part that we approached the Ministry of Justice to get their endorsement on this concept as well from a legal perspective. So with regard to the Ministry of Justice, we did get their legal support in March of 2011 to permit the practice or their agreement with our definition of brain death, equating death. And then, of course, other important aspects that we are working on include building an OPO, organ procurement organization, and establishing the appropriate funding. I should say that in UAE, and more specifically in Abu Dhabi, our healthcare system is going through a tremendous reform. So we have our system focusing on regulatory aspects, payer system and provider system. So with that, our hospitals are going through, they used to get the government hospitals block funding, but they are going through DRG system funding. So that distracted a little bit the program, but I think we are in the final stage. Now, this is our transplant team as of 2010, and I just wanted to build on what my colleagues highlighted in the GCC, and I think what Dr. Anounu will also highlight, that we have to build on the synergies in our community in order to go to the next level. Because we tend to duplicate, we tend to underutilize resources when it comes to surgical teams, when it comes to so there are lots of lessons to be learned from Eurotransplant, from North American UNOS, and I think the saying that the whole is greater than the sum of its parts is really true when it comes to this area, because if healthcare is a teamwork, well, organ transplantation is even more so. The other part that I think we clinicians sometimes overlook is that for any program to be successful, it has to make clinical imperative sense, and also it has to have a good business reality sense. It's just like the pendulum clock. If we focus too much on the clinical side, it may lead to resistance when it comes to the other stakeholders in our system, whether it's the health system financing. So it is important that we build the synergies to include, yes, everything has to be approved by the clinical team, but The clinical team has to understand the business language. And if we have different hospitals, even belonging part of the same owner, you will see some resistance in them sharing resources, let alone if we were talking about sharing resources beyond borders. So I'm just calling for our collective effort in this audience to try to go beyond the borders and build solid programs that can stand out. I'll just refer you back to the previous map. Although this is in Dubai, but Dubai is in UAE, in the GCC, in the Middle East. So forget that this location is in UAE, it is in the Middle East. What I tell my healthcare administration colleagues is that building the hard infrastructure, the buildings, of whether it's hospital or other entity is important, but we all know that it's even more important to take care of the soft infrastructure of any system. Take this, this venue, for example. The programs that are here are more important than the venue. Of course, we can't argue of how nice this place is. So with this, we can hopefully build something together that we can be proud of and meet our patients' expectation in promoting ethical standards of transplantation. These are two, on one side you see a new dialysis facility that is completed to be commissioned in the next few months. And on the other side is Al Mafraq Hospital, groundbreaking started to be prepared in 4 years' time. And I would like to take this opportunity to highlight to you that MESA 2012 is going to be in Abu Dhabi from the 1st to the 4th of November. We will also have, in addition to the 13th Congress of MESA, we will have the 4th Middle East Transplant Games and also the MEDCO transplant program. And the venue is already selected. It's going to be in the new Abu Dhabi Exhibition Center. So we welcome all of you there, and thank you very much.
The next speaker is going Dr. Tawfiq Khoja. Dr. Tawfiq Khoja, no, sorry, we'll have Dr. first from Yemen, Dr. Ibrahim Al-Nunu. Dr. Ibrahim Al-Nunu, he's graduated in '83 from Al-Mansoura University in Egypt, and he did his MD in urology in 1993, also from Al-Mansoura. He's professor of urology in Medical College of Sana'a, and at the moment director of the Nephrology and Urology Center in Al-Thawra Hospital in Aden, in Sana'a.
Bismillah ar-Rahman ar-Rahim. Again, I am the student of Professor Ghunaim, and Professor Ghunaim, who helped us in the beginning and initiation of the renal transplantation in our country. Also deeply thanks for Dr. Faisal Shaheen and Scott, who helped us later on in the same field. Our experience organ transplantation mostly is the best for organ failure replacement. The first corneal transplantation was done in our country in 1975 in the Thawra Hospital. The first renal transplantation was performed in May 1998. The first pediatric renal transplantation was operated in March 2011. The incidence of end-stage renal failure in our country is 120 case per million per year. Renal replacement therapy was first introduced in our country in 1978 in the form of hemodialysis. In 1996, we started an experimental project for renal transplantation in dogs to have a well-trained team in transplanted surgery. 2 years later, in May 1998, the first renal transplantation was performed. Sporadic cases were done later on, and the regular renal transplantation started in our country in 2005 in the Urology and Nephrology Center in Al Thawra General Hospital. We are following 982 renal transplant patients. 148 were transplanted in Yemen. Between May 1998 and July 2011, 148 kidney transplants were performed. The majority of the patients were male. Their age ranged between 11 and 55 years. The original kidney disease is chronic glomerulonephritis in 59, chronic myonephritis in 33, and chronic tubulointerstitial disease in 17, focal segmental 3 unknown in 31. We select the patient according to the age, duration of hemodialysis, previous transplantation, and proper tissue matching, and all our donors were live-related donor. Primary transplantation were done in all cases except one, which is transplanted for second time. Cold ischemia time was 14 to 68 minutes, and no induction therapy were given. The transplanted surgery, the graft artery anastomosis before 40 years anastomosis to the end-to-end to the internal iliac arteries, and after 40 years all the arteries into side to the external iliac arteries and end-to-end anastomosis in the external iliac vein, and the ureter reimplantation, the bladder via modified Lish-Urquhart techniques, classically without stenting. And this is the graft after removal, and this dilatation for the graft artery, external iliac vein, anastomosis of the graft vein to the external iliac vein, finish with anastomosis, and this is end-to-end anastomosis of the external iliac, internal iliac artery to the graft artery after declamping, and this is creation for the reimplantation of the ureter in the bladder, and this is the mucosa, and this is after reimplantation of the ureter. The immunosuppression started at the beginning, 12 cases with 2 immunosuppressive drugs, which is the steroid and MMF, because at that time we have no estimation for the cyclosporin level in the blood, so we started by the 2 drugs, and later on we started with the triple therapy, steroid MMF, cyclosporin, and steroid MMF tacrolimus. In case of acute rejection, we use the methylprednisolone 500 mg for 5 days, and in case of steroid resistant, we use the ATG. This is one of the publishing in the Saudi journal. The follow-up period 3 to 160 months, primary renal graft function in the 148 recipients is about 96%. Our surgical complication, vascular thrombosis in 3, urinary leak in 12, which were treated conservatively, lymphocele in 2, one of them treated by laparoscopic multiplication, and wound-related like infection. And the medical complication, acute rejection in 10 to acute tubular necrosis, and CMV2, and malignancy Kaposi 1. The follow-up recently, living with function graft 138, living on dialysis 1, and died on dialysis 1, and died with graft failure 3, and died with graft function in 5 patients. In conclusion, renal transplantation is a good achievement in our country. All patients received renal allograft from living-related donor. The patient and graft survival rates are comparable to other reports. Again, deeply grateful and thanks for my professor, Dr. Ghunaim, for his unlimited and continuous help at the beginning of this program of renal transplantation, and also special thanks for our colleague in the Urology and Nephrology Center in Mansoura that trained our team in all specialists. Liver and heart transplantation in our country, we are following about 22 patients, liver transplant and 1 heart, and all of them transplanted in abroad. And corneal transplantation, the first corneal transplantation was done in the 1975 in Thawra Hospital. We have 3 centers for corneal transplantation. About 2,500 were transplanted in these centers. This is our fatwa for the organ transplantation law. And by this and the law and the guidance of the GCC guidance for organ transplantation, our program of transplantation will be improved. And thank you very much for that.
Now is Dr. Muhammad Ali Al-Haidari is going to talk on behalf of Dr. Tawfiq Khoja on the GCC Transplantation Committee achievement and perspectives.
Bismillah ar-Rahman ar-Rahim. Mr. Chairman, I would like to introduce myself. My name is Muhammad Al-Haidari. I am coming here to deliver talk of General Director of the Executive Office. Executive Office of Health Minister Council was established in 1976. It is before the council of the GCC Council. The Minister of Health Council, that time they are busy to fight communicable disease, malaria, measles, vaccination, etc. They don't realize the importance of the transplantation until after 16 years of establishing this office. So in 1992, they established this committee, Transplantation Committee, and they realized that this is very important, and they pushed them to talk about organ transplant sharing, about procurement of medication items for transplant or kidney dialysis, etc. They put specification for group purchasing department, and they are busy in that. It is so weak. There is no activity, because also in the member of the state, they are also weak in the facility, laboratory, personnel, etc. But nowadays, the committee is the most successful committee in the GCC state, in our office. They met about 10 times every 2 years. It is very long period, but the most important, this committee member, they are so professional, most motivated. They communicate together, maybe daily. They gathered in the local event or internationally or regionally, And from the last speakers, you saw the cooperation between this group in each state. So this committee is successful, and I hope so that we will utilize the resource and the facility in each state and the personnel. Achievement of Gulf Committee, they put Congress in 1998, the first one, setting unified law for organ transplantation, GCC, setting the unified Gulf manual for organ transplantation, the GCC, setting rule and specific form for registration of organ failure patient, setting the media plan for dissemination organ donation culture in the member of state, preparation of manual for prevention and detection of organ failure in the number of state, compilation of infrastructure organ transplant organization, practice donation in kidney transplant, exchange experience with other member states, establish of donated organ exchange network between the member states according to the rules and constitution set in the unified manual, sit under supervision of the Executive Board of Health Minister Council for cooperation and the training, continuing education, conference, etc. Celebration of organ donation Gulf Day in the member of the state. Hosting the second, this meeting, of course, ensure of the royal degree in the kingdom, allowing utilization of the council state citizen of donated organ and their treatment in the kingdom. And of course the Saudi Scott also put a pressure for more cooperation in this matter. There is a lot of degree from the Minister Council, all of them related to push this committee and the recommendation of committee to be implemented in the GCC state. The most important one of this is putting legislation to organize organ donation and the transplantation. And you saw from last speaker, all of them, they start doing legislation for that. Spreading, establish of organ transplantation as well as organ donation center, strengthen exchange between these centers. Of course, training of nurse and staff. Another one, adapt WHO declaration or recommendation to be self-efficient in the donor, so locally. Community education, conduct field survey, the most common disease, what is the cause of this failure in organ failure, etc. I think the Saudi Center for Organ Transplant now become a reference. I think the committee last 5 years, they are more stronger than before. They are working very hard, and I hope so that every citizen in this region will get benefit from this cooperation group, the transplantation group. Thank you very much.
Thank you very much. I think I would like really to thank all the speakers because we are exactly on time, 90 minutes. Maybe there is room for a question or two only because we want to leave this room 12:30 sharp. Yes.
Can you hear me? Yes. I have a question to Dr. Faisal Shaheen. I have seen your presentation, and I have seen actually there is a major effort done by the Scott for transplantation, and the number of ICUs is huge. So theoretically speaking, there should be a huge number of brain dead patients. But the number used is is not optimal, is not the number that we would cover our shortage. And I think part of it is that there is no enough education for the public about brain death, as well as the need for donations. I have been faced with patients where brain death diagnosed, either the family is not convinced that the patient is brain dead, or they don't consent for it. And I have seen quite a few cases like this, and they are optimal donors, and I think if we educate the public enough about donations, probably will solve part of the organ shortage that we have.
Respond to this, please.
Yes, thank you very much, Dr. Shaib. Statistically, we should have around 900 to 1,010 brain disease cases in our country. This is according to the literature and to the reference worldwide. And now we got around 615. We know that there is a significant number which is not recorded. There are many factors for that. One of the factors that it could be that this brain disease case is not diagnosed before 6 hours. Our protocol said that you cannot report any case as a brain disease except after 6 hours maintenance in intensive care. This is one of the reasons. Second, I didn't think that our intensive care is enough. We should work more to have more intensive care. I still a good believer that if we have more intensive care, we will need more intensive care, but we should have dedicated bed for brain disease cases. Still, the pressures which are given to the intensivist or to the nurse in intensive care from the patients who require the bed in intensive care is huge, and that's why if we do like what's going on in Spain, that we should have dedicated place for the brain disease cases to be taken care by another team completely different from the intensive care will be better and ideal. The third point, which it is exactly, I agree with you, that we should have more communications with the intensivist and with the people in intensive care. If we are keeping ourselves away from them, we will not hear too much from them, because this is a lot of work. Working with the brain disease case is not easy. It needs a lot of work, it needs a lot of medication, it needs a lot of dedicated people who are willing also to work with you on a program from their heart. And in relation to this, public, if you work with public, again in my own experience, that we should work in public, but not to give to the public a very high expectations, because if I am in a public and I know about the brain death, the probability to have a brain death and to be admitted to intensive care is very, very, very minimal. But if I am in ICU and I die in ICU, the chance to get a brain death is 14%. If I am in a hostel and I died in the hostel, the chance to be a brain death is 2%. So if you compare all of this, our target mainly should be to the intensive care, to the hostel, to increase the number of the ICU bed. I'm sorry that I take that long time, but I think it was an important question.
Thank you very much. I want to bring the subject, the discussion to the subject, which is the collaboration and cooperation between GCC countries. The experience we had, at least in liver with Kuwait, has been very fruitful. I'm just wondering why, what are the steps taken in order to replicate this experience in other GCC countries? I mean, also to some degree in Qatar, we've been receiving livers from Qatar as well. With population, big population like in Oman or in even Emirates. Now, I think there is big potential that will, the GCC country can collaborate in terms of increasing the donor pool. So maybe this will be the concluding remark from Dr. Faisal Shaheen regarding the collaboration in terms of increasing the donor pool.
I agree with you, Mohammed, that we should work hard in order, not only GCC country, in all Arab countries. If, for your knowledge, we lost a couple of cases in Lebanon, which they don't utilize the liver, they don't utilize the heart, and I am here with our colleague from Lebanon, Dr. Sivan, and working hard in order to have formal collaboration between us and Lebanon and to have exchange. It is not necessary now to say that who is going to win, who is going to take the organs. Let us work. I take the organ today, tomorrow I will give you organs, even if it takes time, but we will have such collaboration. In GCC country we have a problem before, and we should admit that in transparent way, that some of GCC country were depending mainly to send their patients abroad. This door is closed, even if it will become more tight, and it will be closed. So we should depend about our own resource. And by this, the GCC country ICU will be opened for us and for all of us as a collaboration. This is the future. This is the very near future.
Thank you very much for this concluding remark, if I may say. I would like to thank my co-chairman, my co-chairwoman, and I think it's time for lunch now. Thank you very much. I'm sorry, is it lunch or a session? Lunch.